want to introduce Rebecca Addo from SHARE to do the next lecture.
Thanks, Steve. So for the next section, I'll be taking you through some of the practical issues that you would encounter with regards to the costing aspects of economic evaluation. So at the end of this particular lecture, we would want to understand the link between resource use, pricing, and cost. So when we talk about cost, what are we costing? You need to know what you are costing. So that is when we talk about resource use. And we would also want to explore how we can measure these within clinical trials. And we would also be looking at, in the absence of clinical trials, how do you get access to these resource use and how do you cost them? If you, let's say the economic evaluation have been an afterthought, you've already collected your data, how are you going to go about it? But we always encourage that it's not an afterthought. You think about it when you are designing your programs. And we would also want you to understand how we value these resources. So you've identified your resources, all right. How are you going to measure it? How are you going to value it so that you'll be able to put it together to get your incremental cost effectiveness ratio that Steve has already spoken of. And we would also go through how do you account for the impact of time. As we know, most of health interventions, the outcomes, we can get it over a long period of time, the benefits. So how do you consider that when you are costing it? All right, so this is just a recap. When we talk about economic evaluation, we are looking at two alternative programs. So most of the time, you may want to compare an existing program to a new one. It can also be that there are two different programs that you want to compare. And in comparing it, you just don't want to look at how it just looks in terms of funding and in terms of getting the best out of it. You want to look at both the cost and then the benefits, that is the consequences. So if you have two choices, choice A, choice B, you want to look at how much each costs. You also want to look at how much benefits we can get from it. So you just don't want to be so focused on the cost aspect of it. You also want to know how it's going to benefit the population. And you put that together to get your incremental cost effectiveness ratio, as Steve spoke about. Okay, so I'm gonna take us through just a very quick exercise here to set up the platform for us to talk about the practical issues. So this, as we see here, stereotactic ablative body radiation therapy. So it's a type of radiation therapy that is used in cancer treatment, and it's quite innovative. So it's, it uses precision to deliver radiation therapy to a particular part of the body. And because it's very precise, then you avoid the spread of radiation to other areas of the body that you don't intend to radiate. And it's been used to treat a lot of, a range of cancers, and it includes lung cancers, liver, kidney. So you want to just be so precise. It's not like you put a person in and everywhere gets radiated. So with this in mind, what do you think? I know I'm not a radiation therapist myself, but then just giving you a context of how it looks like. What do you think are some of the resources, or in simple terms, some of the things we would need in rolling out this, in using this survey? That's how I'll refer to it, to treat lung cancer. So let's say a patient have lung cancer, and we want to use survey to treat the patient. What do you think are some of the resources that we would need?
You need the machine. You need the radiation therapists who will deliver the care.
Yep.
You need the nurses who will provide patient care to the patient around the treatment. You need the people who run radiation therapy units, so all the admin staff, cleaning, all that kind of, but I guess they're indirect costs. But yeah, that's all I can.
Yep. There's someone at the back too.
I'm just considering from a hospital perspective, and there's the utility costs, there's space occupancy for such a therapy. Then we would also consider that what's additional to what's already delivering. So that's the incremental component of that. Then also potentially the waiting room usage. And other medications that to follow from this therapy.
Okay, great. So just stressing on what she said. So we've had different types of costs here. There are some costs that are indirect. So even though this is what we intend to do, there would be other cost centers that would be incurred because of this intervention. And then there would be other drugs. So if this particular intervention is going to result in unintended adverse events, then we would have to treat these as well. And there is the hospital cost. In terms of capital cost, we'll be using a space. When patients come, they will wait in the waiting room. So all those are resources that goes into it. So as you can see, some are very direct to it when you talk about the machine, the nurses, but then some are also indirect, but they all go into it. Please, go ahead.
Hi, sorry I missed the beginning. Are we already giving people radiotherapy in this setting?
Yes, we are.
So we have like a bunker and radiation safety equipment, and we're not going to send it to a tent somewhere.
Yes. So all these are the resources that we are going to need to deliver this intervention. So I think we've mentioned most of it, but we forgot our patients here. Most of us have the thinking cap of managers, hospital managers around, so we forgot about our patients. Some of the things that we consider is also the cost to the patient. And these things come in when you decide on which perspective or which eye you want to use in doing your analysis. So with regards to patients that we've not mentioned, you want to consider the patient's time. The patient's time to come for their treatment. Some would have to take some leave days off. How do we account for these when we do our economic evaluation in terms of cost? And some patients also pay out-of-pocket costs to see specialists, out-of-pocket costs on top of what they can get from their Medicare benefit. So you have to consider all these things. So we'll keep coming back to this particular example throughout our presentation. Okay.
Thank you. Well, this is just a quick question about the granularity of the costs. So we didn't mention like the gown or the PPE or cleaning. Is this the sort of stuff you'd get to that level, or do you kind of don't go too deep?
So you don't go too deep. You want to be as focused as possible for this particular intervention. But then it also depends on the approach that you decide to use. Either you do from top to bottom or from bottom to top. So it's either you know that these are the resources, so you cost them. But when you take a nurse, for instance, the nurse, it's not that patient alone that the nurse will take care of during the day. So you would want to cost the time, but then in terms of the gowns and other things, unless it's very specific to it, then you would want to take it out.
So this is even more indirect, but what about the cost to the environment or climate change, the cost of the production of that new equipment and its carbon footprint?
So these are things that are coming up And there have been consideration for adding it, but to the best of my knowledge, we don't, not yet. But I think with time, people would want to see these things. Yep. Richard?
There are methods in development now about broadening that frame of what we include to actually look at some of those environmental impacts. As Rebecca mentioned, though, it's quite nascent, and as you can imagine, we tend to focus on what we can observe as an environmental impact and forget about all the other things that may or may not happen, like impact on travel, like impact on disposal. So it is a growing area, but it's quite new, and I think I've only seen one published paper that does it, but there's a group at UC who are focusing.
All right, okay. Thanks. So with regards to cost, you want to consider these principles. Another question? Oh, sorry.
Sorry. Is it possible to account for the waiting time, like if it's a niche kind of treatment, in terms of their mental health or any other deterioration, from the time they're waiting to access this treatment? Are we able to account for that as well?
Yes.
Cool.
Yeah. Okay. So we want to get to know these principles when you are considering cost. Opportunity cost. That is what economists always talk about. It took me a long time to wrap my head around it because I have a health background. So it's just in simple terms, what would you have used? So let's say you have $1,000 and you've decided you want a new phone, or let's say $2,000 now. iPhone doesn't cost that cheap. And so if you decide to buy iPhone with this $2,500 that you have, what the opportunity cost of getting the iPhone is what you could have used that money to get. Maybe you could have used to get about 4 pairs of shoes, a dress, or you could have used it to invest or anything. So that is the opportunity cost. So when you are thinking of costing a resource or costing in economics evaluation, you want to think of what else could you have used that resource for. So we always have that at the back of our mind because there isn't one specific thing that you can use that particular money or that resource. There is always something else that it could have been used for. So you want to bear that in mind. And we also, in practice, we use the average cost. We want to use the average cost to do our assessments because then you are capturing whatever is available, you are averaging it, you don't take the extremes, but we do sensitivity analysis to test if we had used this, maybe the cheapest or the highest, what would have been its impact on the evaluation that we've done. And our interest is also in incremental because we want to know how much more would it cost. You are comparing two interventions. So you want to know how much, if there's an existing one and there's a new one, and the new one is pitching to be better. You want to know how much more it would cost to implement that new one, or even if it's not that good, that is why we consider the benefits as well, but we always want to see the incremental. What is the difference? Okay. So these are the 3 main things that we'll be talking about today. So when you think of the cost, going back to the survey example, you want to identify the resources. So you have an intervention. It can be a public health intervention. It can be a drug. It can be a technology. It can be a procedure or diagnosis. You want to know what resources that you want to, the resources that could be used to undertake that particular intervention. And as we've made mention of, there are a lot of resources that you want to consider. You want to consider the labor that is going to undertake that particular intervention. Even if it's a drug, if it's an injection, a nurse is going to give it or a doctor is going to give it. So there is a labor component to it. And you also want to look at capital costs, where it will be given. That is where you talk about the building And if you are comparing two interventions, so let's say for this radiation, there are two different types, or you want to give a single one compared to multiple ones, they are going to use the same space. So in considering the resource use, you have to think of resources that are similar between these two interventions. If it's the same, then you are not going to consider it because it's not an additional thing. Other things that we look at in addition to labor is consumables. So once you've identified what resources you need, then you need to identify how you can value it or how you can measure it. So we come to our unit prices. We know that we need a radiation therapist to do our survey. How much does it cost? The time of a radiation therapist to plan, to implement, and to do this. How much would it cost our physicist who is involved in the planning? So those are the things that you want to do. And then we do the valuation, that's the costing. So you assign the cost to the resources. So we know that a nurse is involved, and it will take about 30 minutes of a time. How much does it cost per 30 minutes? So you assign, and then you put all these together to get your cost to the intervention. So before you begin, I think it has already come up, you want to think about which approach you want to use. Both approaches are okay. They come with their own pros and cons. If you want to do a bottom-up, or you can also call it micro-costing, then you want to identify all your resources. So you want from bottom to up, and then you cost them. But when you talk about top to down, then it's like bundle of resource use. We know that, okay, we may need labor, we need that. So you take it from that bit. If it's nurses, you say, okay, a nurse is involved, this is the cost of it, so I know that a nurse is paid this time, I'm going to divide it to get the bit of time that I'm going to need from that particular nurse. So you go top to bottom, and bottom to top, sorry. So with this particular one, it's faster, it's less intensive because you can get the gross price from databases and it may be available. But for the bottom up or the micro costing, you may need to come out with a data collection tool. You may need to give patients case report forms. You may need to give patients diaries and to collect all these resources that you've identified. It's very precise and accurate, but then it's intensive. So these are the things that you want to consider. Both approaches are good. And most of the time, too, you end up using both approaches because there may be times that even though you've identified these resources, you cannot collect the data from top to bottom. So you have to rely on existing data to do it. Once you've identified how you want to collect your data, you also need to think about the perspective. So who is going to bear the cost? Is it the hospital? Is it the government? Is it the patients? Is it the society? So based on what you decide, it would also inform the kind of costs that you collect. I'll give you an example between a societal perspective and then a health system perspective. So we identified that we need to collect costs on the use of the hospital premises, the use of buildings, the use of the machines. So if we want to look at the cost to the government or the cost to the hospital, then those are the only bits that you focus on. You don't add patient to it in the mix because they don't bear that cost. But if you want to go a societal perspective, which is what is used typically, but then it also varies from health system to health system depending on who the funder is or who the payer is. That bit, you want to consider the cost to the patients because the patient's time, taking the patients out of work, it's going to affect the society. So you need to consider that. And if you, depending on the approach that you decide to use, it would inform the type of data that you would collect. But even in instances where there are a lot of health technology assessment agencies that just look at the cost to the government, but these days they still have an additional, they can add an additional analysis to make a case of how it affects the patient as well. So it's always good to consider collecting data on the patient, the impact on the patient, the cost, even though it may not be the approach, but you can use that analysis to support your case. So now we know what we want to do, the type of costing, we know our perspective. How do we go about our costing? As we've already mentioned, you need to first identify your resources. We know the resources that we want to. And in thinking about the resources, it's not just about the intervention. There will be impact on other things, such as maybe the patient may already be in another drug. There may be unintended side effects from the particular program. So you need to consider all these inputs. And then you also measure. So when you take like the machine, how many times are you going to use this machine? You have to consider that. When you take the time of the radiotherapist, the time of the physicist, the time of the nurse, how many times are we going to deliver this intervention? So you need to consider that in your measurement. So it's not just about the resource, it's about how many times you are going to use the resource, the quantity, and then also the cost. So in valuing, you assign the unit prices to it. So we will go into detail with each one and then cover what we might have missed. I think we've spoken about most of these, but these are things that you need to think about. And it's always good as a researcher to work with people who work in that particular setting. So if I am the health economist on this particular intervention, the survey, I don't really know much about radiation therapy. So I would have to work with a radiation therapist to identify all these resources. If you are working with a neurologist, you have to work with them because they are the ones who knows what goes into it. So it's a team thing. And you want to also check, once you are talking with them, you want to be sure that everything that goes into giving these resources have been, this particular intervention has been captured. So who is going to deliver it? What are the different components of care? So there may be radiation, there may be additional therapies. The person may have to go through maybe physio, go through other things, so you need to consider all that. And what do you measure? These are just examples that have been given. So you want to consider the drugs that may go into it. You want to consider medical services. You want to consider the radiotherapies. If there may be surgical interventions, you want to consider it. So all these are things that you consider when you are doing your identification. Once you've identified, I think there may be a lot of repetitions, you want to
Rebecca.
measure.
Hi, Rebecca.
Hi.
Sorry. Can I ask you to briefly go through that interesting diagram figure on the earlier slide? Yeah, like what's that about? Thank you.
Yeah, it's just a logic map as to how you can start like in identifying your resources. So let's say a patient who needs survey, or even if it's, let's say a particular kind of treatment for a cancer or something, you want to first diagnose. So you just have to, it's a logic map that guides you. You have to take it from beginning. Okay, this patient needs this particular treatment. How do you give it? You first need to diagnose. You diagnose, you know that this patient has it. So if the patient has it, then the patient would, if the patient is symptomatic, the patient will need this particular treatment. If the patient has like progressed with that particular illness, if it's cancer and nothing much can be done, then this patient will progress to end-of-life care and may die. But if the person is not symptomatic, then the person goes to a different branch. So the person would have to go through watch and wait, and then the person would have to go through the process of screening again. So this is just a logic map to guide you in identifying what you need, depending on what kind of intervention that you are looking at. Any other question or contribution? All right. Okay. So in measuring your costs, you also need to identify data sources where you are going to get the data. And one area that we can get is from clinical trials. And this one is direct. You develop a case report form, and then you collect your data. In its substance, there are other administrative data. Medicare, I think a presentation this afternoon will go more into it. To be able to use Medicare data, you need to get consent. So when you are collecting the data in the trial, as part of the consent, you need to note in it that you will be accessing their Medicare data, and they need to give you consent for it. If you don't, then you have to go the other way, which is a long process. And I think Steve or Richard would talk about it this afternoon. There are other forms of data collection that we do, patient diary and clinician surveys. So if you want to know patient time, patient out-of-pocket spending, you can provide patients with a diary, and then they put it there. But if it has not been done during the trial and you still need this kind of information, you can also do a prospective data collection. So you have a questionnaire, and then patients will remember what they did. But then in these instances, there is always recall bias, because you may not remember what you even ate 2 weeks ago to give a detailed. Okay, and there's also clinician survey. We can also ask clinicians about things that we need. So these are all sources of data. This just explains how we collect these data. So the clinical trial data, as I've mentioned earlier on, we do with the case report form. Administrative data, you would have to access it, and you would need ethical approval to access these. And there are some of them too, you need consent from the patients to be able to access them. Hospital use, you want to consider admissions, emergency care, non-admissions. So you want to think through these. When you say hospital use, a patient can go on just a day care, day surgery, and that is it. Someone will go to the emergency department. The person may be there for some hours and discharged, or the person may move on to be hospitalized. So hospital use, there are differentiations, and you would want to capture that. And in Australia, there is the Australian Refined Diagnosis Related Group that has average costs of things that are done in the hospital. So in terms of hospital use, you can rely on that as a source of data to estimate your costs. And there are capital costs like building, machines. You also want to consider the life expectancy of these. It's just like when you are lodging your tax and you put in, you have a car, they consider depreciation over time. The same applies here. Okay. So patient costs, as I've mentioned, it could either be collected retrospectively or prospectively. And in all that you use it, you need a data collection tool. And another thing is productivity impacts and informal care. And you want to consider these when you are collecting the data from the perspective of the society. informal care, we know a lot of us give informal care, and it's unpaid. But the fact that it's unpaid doesn't mean that it doesn't have a value. So you need to consider these informal care when you are considering the cost, because in the absence of the carer, if someone was to take on that job, it would have been paid. So you need to consider that. And there are different ways of measuring that. Human capital approach, willingness to pay, and replacement method. So the human capital approach looks like, okay, how much does it cost a carer on the market? Willingness to pay, you ask people, how much are you willing to pay to stay home or to pay someone to be a carer, so that you use that to value. And the replacement method, it looks like how much it will cost, the time between when it will cost to replace someone who should have been working and the person is not working because the person is sick or the person has a carer responsibility. So in measuring, what do you consider? Are these resources shared across the same interventions, or are they different? Are there capacity constraints? So in terms of, is there a spare capacity? Or maybe you may have identified that these are the things that are needed for this particular intervention. But in actual fact, when you go to maybe rural areas, you may not have all these things that you need. So in that case, what's going to happen? You need to consider some of these things. Are there economies of scale? If you are expanding it, will it lead to saving some money? Or we would be in the previous position? Is there a learning curve? Especially increased efficiency over time and scale. So if it's a new, let's say, surgical intervention, a new skill, would there be a learning curve? So over time, would people get better at doing the things? And because of that, you are going to get much more out of it. You consider these things. Is there any artificial inflation of cost? So what we see is that in clinical trials, more resources are used. Because we are particular, we want to make sure that this thing works or doesn't work. And it may vary in practice, the resources that we use. So in terms of monitoring, the number of diagnoses that they get, diagnostic investigations that they get, may not really be applicable in real life clinical practice. So most of the work that we do, we look at the applicability and also how you can transfer data from one setting to the other. So what has been done in the clinical trial, is it applicable when you come to clinical practice? How do you include overhead costs, like the cost of the manager, the building costs, let's say electricity, that is powering the whole hospital, where your particular intervention sits? How do you allocate this cost? At the end of the day, you just need to balance these approaches. If you are going for case report forms from clinical trials, or if you want to use Medicare data, all these comes with their own advantages and disadvantages. So you just need to think of what you need at a particular point in time and weigh the benefits you are going to get out of it, and then decide which way to go. So once you've measured, you've identified the sources of data that you can use to measure the resources that you've identified, you come to valuing. So if you are doing bottom-up micro-costing, you just have to multiply the volume of the resources by the unit price to get your overall cost. If it's top to down, typically you have it valued. So the question is how you are going to allocate it to your intervention. So you know that, okay, we can consider like electricity. So maybe it costs a month this much to run the hospital. How are you going to allocate a bit to your intervention? So that is the only thing with the top to down. But both these methods are good, and most of the time we use it together to evaluate or value a particular intervention. Yeah. So always just think of the opportunity cost. So during interventions, especially when you go to rural areas or low middle income countries, there may be some public health intervention that maybe the local leaders will say, okay, we are willing to provide you with a space to roll out this program. The fact that this has been given to you for free doesn't mean that it is free when you are costing or when you are doing your economic evaluation. So when you are doing your economic evaluation, you need to value things that has been given as free. If there have been volunteers who have decided to help, let's say we are doing education on vaccination and people have volunteered to do that, you need to value their time and add it because of opportunity cost. Because in their absence, you would have employed someone to do it. So you need to consider that. And it also gives us an idea of how and how much it's going to cost to roll out that program. So you want to capture everything as much as possible, even if it has been given as free. And there are publicly available price lists. So if you are looking for prices for resources that you've identified, there is the MBS, there is the PBS. PBS gives you cost of drugs. MBS gives you cost of medical services. And when you go to other countries, they may have something available. Some have hospital data where they have cost of things. Some have national health insurance schemes where they cost interventions. So you can rely on these as sources of data that you can use to value. So what are some of the considerations when you are valuing these costs? You need to think of, can you vary the cost based on age, sex, disease severity, comorbidities, or urban and rural divide? I want to know what people think in terms of if you are costing an intervention and you know that these interventions will be given in the rural area and it will also be given in urban areas. The cost of, at times even cost of labor varies with these rural and urban. So what do you think about this? Should we consider disease severity? Should we consider age? So the value, so a young person, an older person. Should you consider disease severity? Or it's okay to just do it on an average basis? What do people think?
I think a lot of it will depend upon the question asked. So obviously they should be given an extra, let me say, credit for example, if they come from a poorer background or geographically removed background. I think that automatically will increase. So something has to be added on top. That's my take on it. But a lot of it will depend upon the question asked.
Any other person?
I don't think an average would make sense because the urban areas are going to be much more overrepresented. So you need to do it per population. So cost in the rural area plus cost of the urban area by population, and perhaps average it out that way, not by the whole amount.
Just to add to the last comment though, but would someone in a rural area have to travel to a city for this complicated equipment? They're not going to have it, right? So that would add to the costs for the rural area.
Okay, great.
I was going to say, how do we factor in equity as well in our model and supply? there might be 3 other ones next door in the city and none in the region.
Okay.
So there is Steve mentioned before about equity being an important consideration by many of the communities who use this sort of information alongside of what we're doing. But there's also a very large body of work ongoing in health economics at the moment to embed equity in how we actually work out these numbers. So there's distributional cost effectiveness and equity-based cost effectiveness analyses that are looking at how we can make better use of information about individual subgroups, and in particular individual subgroups of need, to then incorporate that into our economic evaluations and our assessments of cost effectiveness. The challenge is the data required. And as many people around this room will know, we don't have good data on many of those subgroups of interest. Getting them in our regular healthcare settings is one thing. Getting them in a clinical trial can be even harder, where you've got diminishing numbers of individuals. So the technique is there, and the technique is being developed and is being progressed mainly by, I've forgotten his name, but Dr. Cookson. And so those techniques are available. We just need to think about the data that we have to inform it. That old adage of garbage in, garbage out really plays strongly in health economics.
Thanks, Richard. Veg, do you want to add something to the urban-rural divide with regards to costing?
No, not really. Thanks. Thank you. Hi everybody, I'm Virginia Wiseman. No, I think the points that have been raised are really important. And as Richard said, there's a lot of people interested in this area of work. It's particularly important in the settings where I work, mainly in low and middle income countries. I think, measuring the trade-off, because you can often demonstrate that something's very efficient. It's very efficient to do it this way, but you're actually going for low-hanging fruit. You're getting the easiest people to access, and it's proving to be a very efficient intervention. But actually, you might be missing, a very large chunk of the population that are very deserving of an intervention or a high need. So it's a very important question.
I just wanted to ask about the question of age or sex. And to me, I'm sitting here going, does this mean that a young person's life is worth more than an older person's life? Is a particular gender worth more? But it's also around, if you are 89, you're probably not going to live as long. So there's all those questions, and how do you put that in? If you've got comorbidities, we've got the issue in studies that we study single diseases, and how is it impacted by comorbidities or the disease severity. I think it's really tricky, but it seems ethical and moral as well as about numbers.
I just had a question.
Sorry. I think that's a really important point, and I think it boils down to the policy question. Look, you could potentially stratify your cost effectiveness by a million different ways. Kids, adults, teenagers, blah blah blah. But is it really sensible to have separate programs for different? If it is, for breast cancer screening, you might have different options that based on different age stratifications. In which case, you do look at the cost effectiveness of screening 50 to 65-year-olds or 60 to whatever. So it just boils down to the policy question, I think.
I think you've just answered my question, actually. But I was just going to ask about how you find that balance between delivering equitable care amongst, many different populations that have intersecting identities versus kind of a pragmatic decision around, because I guess your time is a resource as well. And but I think you've answered that, unless you want to add anything else.
I think it's whether there is a policy question about targeting different patient groups. I mean, it's possible, for instance, if you have a targeted program for Aboriginal and Torres Strait Islander people, that you would do a separate cost effectiveness for the targeting of that group. And, you have to bear in mind for disadvantaged and vulnerable populations, acknowledging the higher cost of doing it is going to penalise them potentially in terms of cost effectiveness. So that's something that needs to be borne in mind. If for instance, you want to look at delivering a program out in rural communities, there's going to be a cost weighting associated with that. So that makes it harder to justify on economic grounds of doing that. So you might need to think of other reasons from a policy point of view for doing that sort of program.
Thanks, Steve. I think we are running behind time, so I'm going to try and finish. So this is just an example of how we present information. So you want to group them in a way that is easy to understand, in a way that is sensible to the reader. The last bit I'll touch on is the impact of time discounting. So with costs, as we all agree, we just, there's time preference when it comes to cost and benefits. And a lot of people would rather have it now than later. If you are offered, let's say, $100, and I'm told, okay, I can give you $100 today, or I will give it to you in 10 years' time. Which one would you prefer? Now? Yeah, most of the time, a lot of people will go for now because you don't even know if in 10 years' time you'll be alive. That is one thing. So in considering costs and in economic evaluation, both benefits as well, we do discounting by factoring into the fact that people prefer to have something now than later. And there is a methodology involved that you can just put in the numbers and it will do it for you. You don't have to really think about it. Okay. So this is just an example of when you apply discounting. So the value of something costs $4.50. The benefits, if it's undiscounted, it sums up 100%. But then if you want to discount it at 5%, in 2020, the data, so we are now in 2023. So if you want to discount for the next year, you have to apply the discount rate, and then you can see that the values, it becomes different because you've applied the discounting compared to if you had not applied it. So it's always important to discount your cost and benefit. So in summary, I think we've gone through this in detail, and you have it in your presentation slide deck, so you can have a look. The example that we went through earlier on. So these are some of the resources, and it takes you through the perspective, the comparator, how you identify and how you measure based on this particular case study. And that is how some of the results are presented. It can either be graphical, it can also be in a table, but table always is easier because you know this is how much exactly it costs compared to diagrams that you want to try and figure out where it falls. But then it's nice pictorial presentation. So in summary, at least if you don't remember anything today, remember that there is always opportunity cost. There is always a cost to whatever you do, whatever you choose to do. It could have been done differently, or it could have the resource that you have could have been used for something else. And you always need to identify, you measure, and you value. Identify your resources, measure them, and then value it. And you need to consider how you are going to go about it, the source of data in doing that, and also discount. Thank you very much. If anyone has a question or contribution, otherwise I would hand it over to my colleague Joe here, who would continue.
Thanks, Rebecca. I just had two very quick comments. One of our colleagues earlier mentioned about, what do you cost and how much detail do you go into? And I think the most practical, useful piece of advice that a guy called Professor Alan Shield gave me when I did my very first costing was, don't get too bogged down in the minutiae. Like something that is very small, might be an overhead cost, I don't know, but it's often your staff, your equipment, it's your treatments that are really the big ticket items. So just always bear that in mind, that you can actually, it's very easy to get drawn into just thinking about cost in this crazy level of detail, when at the end of the day, it's not really going to make a lot of difference. And the second point, I just wanted to emphasise what Rebecca was saying about opportunity cost. You could just cost your program, say you have a lot of volunteers or you have donated equipment, and you just take whatever really cost you as far as your project or program went. But part of the reason you're doing this is for value for other people as well as the people that you work with. So to be able to generalise your results, you need to be able to have that transparency. Or, for example, if the government said they want to scale up your program, if you haven't included a value for the volunteers that worked on your program, well, Queensland might not have volunteers. So I just want to emphasise that it is a very relevant concept to always have in the back of your mind. Thanks.